like to take some of the few remaining seats at the front. And there are some folded up chairs at the back as well if you want to break any of them out, if you can find yourself some space. It's a tribute to the power of the Tim Kelsey brand, that there is such a huge scrum of people here, and also the fact that this is an extremely important subject. So welcome to Policy Exchange, and welcome to this event on using health data to develop better treatments. Now this discussion we're going to have this evening is kind of at the intersection of various things that Policy Exchange is interested in. We're interested in big data, and we're interested in digital government. That's part of why this is interesting to us. Very interested in public service reform and how we can get more for less out of our public services too. So this is something that we're interested in for all kinds of different reasons. And we're also, over the course of this year, going to be doing a lot more work on the technologies of the future, and so a third reason for us to be interested in it. Better use of medical data has a lot of potential in at least three different ways. Better potential for clinicians to access records easily, reduce waste, reduce error. There's the potential for all of us, all of the patients, to get our own data, maybe improving public health, to make improvements there. And then lastly but not least, also to develop better treatments over time. And the context, of course, is that medicine is becoming increasingly personalised. People talk about the end of the blockbuster drug. It's all about increasingly personalised treatments. So that's the thought. The opportunity, of course, in the UK is an interesting one. A lot of people say that we have an opportunity to lead in this field because of our highly centralised health data and our national health service that we've had for a long time. On the other hand, there are obviously some challenges, and this is a very topical issue. A lot of you will have read this piece in The Guardian today talking about some of the challenges as well, thinking about privacy, confidentiality of all of our data, thinking about the IT, thinking about even the financial constraints in trying to do these things. So a lot of challenges, but also a big opportunity. And now, to talk about this issue this evening, we have the key people. Tim Kelsey, in his new role, is the first ever National Director for Patients and Information in the NHS. He was formerly the government's Executive Director of Transparency and Open Data, and knows whereof he speaks. And after he speaks, we're going to have a response from Rowan Silva, who is a Senior Advisor on Policy to the Prime Minister. And those of you who know him will know he's a great advocate for technology in government. So, without any further ado, I'm going to hand over to you, Tim. It's a great pleasure to have you here this evening. Thank you for coming.
Thank you. Well, it's great, and how daunting to have such an amazing audience. So I'm what's called the National Director for Patients and Information in the NHS Commissioning Board, and we'll come back to that because that's quite an important point. And what that actually means is that I'm the Chief Technology Officer, I'm the Chief Information Officer, and I'm also kind of the Marketing Director for the new NHS. And that's the first time, I think, in a public service that those sort of roles have been brought together. And the reason is pretty self-evident. You know, we have struggled for a decade to try and make sense of the opportunity that information technology offers in delivering better health. And one of the reasons we've kind of failed, actually there are some great successes, but one of the reasons we've broadly failed is because the technologists were arguing with informaticians who were arguing with the comms guys, and the whole thing was just a sort of internal row, which lost sight of the broader objective of patient outcomes and public service. So this is a real risk. I mean, first of all, it's a big risk for my boss, David Nicholson, to have hired me, as many people in this room will guess or know. But equally, it's a fairly big risk that we bring these things together after their long history of non-collaboration into kind of try and bring a strategic context to bear. But that's the challenge, and that's the role I've got, which is, frankly, just to do nothing more. Well, it sounds simple, but it's so complicated, which is to unleash, you know, the power of information and technology for patients and those who serve them. Now, I guess pretty much everyone in this room will support that objective, but I can assure you that a small and quite vocal minority of my new colleagues in the health service are not as supportive. And I wanted to start by telling you a story of a recent conference that I went to. I now do quite a lot of public speaking, I mean pretty much every day actually, and I think that's a really important part of the role, because a lot of this is just about arguing the benefits case. It's very little to do with technology, it's much more to do with why, if you're a GP or a doctor or even a patient, this is important for you. Anyway, went along to this conference, and this is a new organisation. I'm not always very well briefed on what I'm about to walk into, and I've been given the impression this was going to be kind of an easy gig, that it was sort of patient technologists and all this kind of stuff. Anyway, it turned out to be some very austere doctors. It was properly doctor-led meeting, and it was a cancer session. And So I walked in and there were literally hundreds of doctors, and I'd got completely the wrong pitch. It was the one I'm about to give you now, you know, transparency, participation, open data, stuff which is vitally important. And I could feel the sort of room draining of its enthusiasm. It was quite an awful feeling. I could see one half, a small cluster of kind of junior doctors and nurses sort of looking excited, but the rest of the room was beginning to drain of enthusiasm. And so I finished my talk, and then I got a first question, which was sort of talking excitedly about, you know, how can small businesses and entrepreneurs get involved in this new movement, et cetera, which was great. And I thought maybe I was winning. And then I got this question from the back, you know, gentleman in pinstripe suit from a appropriately famous public health institution in downtown Westminster. And this gentleman stood up and said, "Mr. Kelsey." This is a terrible sign when you're dealing with doctors. "Mr. Kelsey, you're a visionary," which also is a terrible sign when you're dealing with doctors. "And your vision is total nonsense." And so I then said to him, I tried to, you know, take it on. I said, kind of, it's in a way irrelevant but important. I said, "So, given you just said that, do you kind of do online banking?" And he said, "Well, obviously I do online banking." And I said, "Well, do you get your accounts online, or do you get paper statements and all this kind of stuff?" And he said, "Well, obviously I do, and that's irrelevant." And anyway, we stopped, but I think that in a way the point had been made. The following day, I got this email, which is why I've got this huge pad here, from a nurse who was also in the room, who wrote me the following thing, saying, "I was very interested to hear your presentation at this big meeting last Thursday, and despite some of the anxious responses from the audience, feel that taking the NHS forward into the electronic age that we have become is only a good thing. I'm intrigued to know how you might do this, as for as long as I can remember, we've been told that we will be paperless soon, but it's yet to happen. I still have to keep patient records in dated and tatty folders." This arrived, and then literally, I don't know why, coincidentally, I then got a tweet from someone about 3 minutes later, which said, "I've just met this doctor who said computers are irrelevant to medicine." So I emailed back saying he shouldn't be a doctor. And this then sparked a massive crisis on Twitter. Well, I say massive, but it was quite significant. So I'm trying to paint you a picture, really, of the world that I come from, which is a world that is very largely, of course, you know, in the end, we're all people. We're not doctors or nurses. Understands the benefits that this data-driven, digital, technological opportunity offers us. But there's a really big problem we've got with making the case, you know, making the argument that this is right. So I'm going to try and do that a bit tonight, just to, and not that you don't know what the messages are, but it would be great if everyone could leave this room and be able to, in the lift with that pinstripe doctor, give him the pitch for why this is the most important thing that's going to happen in healthcare and indeed, I think more broadly, in public services in our generation. So I don't really need to rehearse why this is important on a sort of macro scale. You know, I saw some figures. I'm a trustee of the Nuffield Trust, which is a, you know, key think tank in this sector. I was at the board meeting yesterday, and they showed this incredibly scary slide, which says that by 2020 we're going to have a funding gap of sort of 44 billion or something. You know, it means nothing, but what it means is we have a serious problem. And then we have, Roger's in the back there, we have the Dr. Foster data that came out at the weekend. We have mid-staffs coming up. We have the endless cycle of tragedy in relation to lives lost because of ignorance about the quality of services, the inability of the system to know more about how to care for people appropriately. And there's sort of all these, you know, in the middle of that, bizarrely, we had the Olympics, and, you know, sort of suddenly we all really care about the NHS, and yet about 3 weeks after that, we get all this data showing how we're all admitting ourselves into hospital in the tens of thousands for alcohol abuse and obesity, and it's sort of that never have there been more pointless, you know, trips into hospital than ever before. So kind of we have a national crisis with ourselves in relation to healthcare, and I don't think I need to paint more of a picture than that because we're all aware of it. But this is sort of the opportunity to make finally technology and data in particular really make the difference in this public service. And as I said, I think largely this is a cultural issue. So I'm going to get on to the details of what I'm proposing to do in a sec, but I just would like to draw back. How many people in this room have heard of a guy called Devi Shetty? Apart from those who were at the Cambridge Health Network the other day. So Devi Shetty is an amazing Indian doctor. And he runs a practice, a sort of system really, where he's managed to grossly reduce the cost of factory-type elective procedures, hip replacements and so on, whilst massively increasing the the patient satisfaction with those services, and most importantly, of course, the outcomes of those services. Anyway, he gives a much better talk than I do, and he likes to do it in his full, surgical kit with his hat on. And you'll get it on Skype, and he'll give you his talk. And what he does is he takes his web, camera around his office, which is peppered with rather beautiful paintings, and he'll alight on this painting a sort of, a still life of flowers in a vase, and it is actually genuinely a rather beautiful painting. And then he'll ask you, who do you think painted this painting? And he'll say, was it Degas or Monet or whatever? And of course, no one has any idea, and it clearly wasn't one of those artists. And then he'll say, who painted that? It was an elephant. And he trained this elephant to paint this picture, which genuinely is beautiful, with feet, with brushes in its feet. And he paints this picture, and then he says, the reason I'm telling this story is, if an elephant can paint this picture, why can't my villagers learn how to be their own nurses? And what he's done is he's rethought the whole way in which healthcare is delivered. He's given people the tools that they wanted but didn't realise they needed to be able to manage their conditions better. He's put transparency at the heart of his system so that everybody knows the quality of the service they're getting. They actually genuinely, even though all of them, I would say, are less educated than every single person in this room, are making much more sophisticated choices about the sort of service they want to receive than we do. And so the focus of really all of this for me is about giving people the tools they need to make better decisions. And the two operating principles that the organisation I belong to, and I hope the whole NHS and more broadly the whole health and healthcare systems will adopt, are transparency on the one hand and participation on the other. And I don't think we need many more words than that to describe the future of what we want from our health system. So transparency is about data. And I am a data campaigner, and I come at this, unashamedly from that perspective. And this is about a transformation in the availability of data to anybody at all. And people keep on asking me, why would the NHS not charge for its data? Lois was just asking that earlier. Why would we not make it sort of in a way a commercial asset? And the argument for wanting to give it away freely in as large a volume as possible, obviously we'll come back to patient confidentiality later, but essentially the principle that we want to maximise the availability of free-flowing liquid data is because in every other sector the world has in which there has been free data, it has delivered far more value, societal as well as economic value, than situations which data is charged for or inhibited. So the example I just want to leave with you, and I'm sure many in the room will be familiar with it, although it was my idea before Todd Park used it originally, he's the White House CTO, is the weather industry. So, unexpectedly, not financial services, which has got some amazing data in relation, or the airlines industry, but the weather industry is or the weather data is a fantastic exemplar. And in this case, back in the 40s, the Americans had very, serious problems with agricultural productivity. They had very small farms that could not consolidate because a bad harvest, a bad winter meant that the farmer went bust. There was no capital available to those farms to kind of build their plots so that they became commercially sustainable. And after the American agricultural sort of authorities looked at the problem, they came away with a rather unexpected conclusion, which was that if they could stimulate the insurance industry to offer cover for farmers in the event of bad weather, that they would be able to, they believed that would lead to consolidation of farms. So the one thing the insurance industry said for it to develop premiums that would be acceptable in this context was that they needed to make their own weather forecasts. And at the time, the weather data, just as in this country, I'll come back to where we are with this in a minute, just as in this country, the data was owned and not liberated. It was held by the state. It wasn't made freely available to people. So a long, long time ago, 30 years ago now, the American system let the weather data out. Literally, all the raw data was published at no cost. And what's now the weather derivatives marketplace, a fantastically complex and vibrant industry in its own right, now worth about $3.5 billion, has literally been held up by economists, I'm not one, but by proper economists, as the principal reason for America moving from a food deficit situation into becoming a sort of food exporter, because it enabled consolidation. And so when I was in my previous job, and making an argument with the Treasury about why we needed to release our weather data, the argument I made was not because we wanted weather channels or better customer service. It was because what slice did we want of this massive economic opportunity that had burgeoned so strongly in the US. And that's one of the core arguments we now need to make for health data. So you might expect me to make arguments for health data that relate to, say, quality or productivity, and those are real, and I've made them 100,000 times before. You know, Bruce Keogh, it's reduced deaths by the 1,000, giving doctors management information. It's obvious, so I'm not going to dwell on it. Obviously, business intelligence improves performance, but what is not obvious is that if we package this data in the right way, we might be able to stimulate an industry that we can only dimly perceive the value of, which of course is the life sciences industry. And broadly, this is about unlocking the genetic future, which was the subject of that Guardian article we mentioned earlier. And there's a lot we've got to do. And you can see a number of people in the room who are very, important in the development of that genomic future. And this is about creating the NHS, maximising its value to the development of research by packaging up its data safely in ways that will drive all sorts of value, gene sequencing, creating clinical reference resources for the gene libraries of the future. So these are sorts that's a big part of where I come at this from. So I think this is a transformational game, and the data for me is at its core. Now, I say all that because that all sounds visionary and it's important, but actually where we are today is not in a good place. So to get to that future, we have an incredible amount of serious heavy lifting to do. So today, we cannot, this is, for those who know him, Mike Richards is a genius and our cancer czar and a fantastic guy. He says that the biggest embarrassment in his professional career is currently his inability to tell anyone, himself included, how many people are treated with chemotherapy by the NHS and with what outcome. That's an astonishing absence, void. How can we, God knows how much it costs. We probably don't even know that. But not even to know how many people are treated is a big indictment, as an example of a much bigger malaise. There are other issues we have. We know almost nothing really about quality in primary care. We've worried for a long time about quality in hospital care, and we're going to have this potentially cathartic moment about mid-staff. So we had Bristol, we've had periodic terrible tragedies in our secondary care system, but I don't want to say this, and I can see Phil Kozan, who's an excellent GP in North London, saying that I suspect it's going to be quantifiably worse. The emotional response to the fact that when we may realise very, very quickly that our primary care quality of primary care is pretty variable and possibly, in fact, I would say certainly in some cases actually dangerous and harmful. And we just don't know yet because we haven't unlocked the data set. So, an example of that, which we've known about for a while, is that there are currently about 2,000 people a year who die in our healthcare system because they have dementia and they're treated with antipsychotic drugs. Now, there may well be circumstances in which that's an appropriate treatment for a GP to provide, but generally speaking, it's regarded as bad practice bordering on negligence. And we don't know at the moment which GPs are doing that because we can't link the GP clinical record with the prescribing data. These are things so fundamental and so morally unacceptable that we have to move quickly now to end this void of intelligence. So that's my main target, is that. I'm going to talk to you a bit about digital futures and everything in a second, but principally, I'm just trying to get the data out. I'm not even attempting to analyse the data. That's for others in this room to do. I just need to get the flows into the public domain so that or into the hands of clinicians, but so that we can start answering these really fundamental questions. And so, I can't, unfortunately, trail this too heavily, but what was previously called the operating framework, which is the sort of the planning guidance for the system, which will be issued in a couple of weeks. I hope when you read it, you'll see that it contains some bold and real statements of intent in this context, around the data flows, the primacy and importance of them. And the good news about the current system, and this is where I mentioned I'd come back to the commissioning board, is that we now have, whatever you think of the reforms, and there's lots of miserable characteristics to them. I deal with the HR thing is a living nightmare, but is the fact that we now have an unconflicted relationship between the money and the providers of services. So if you were Asda and you had a bad Apple provider, you know, you'd simply shift to another Apple provider. Now, maybe maybe that won't be the brutality that occurs in the new NHS, but for sure, we now have the opportunity to sort of draw a line in the sand. And I think the line in the sand that I hope you'll recognise when the planning guidance comes out says that hospitals, providers of all sorts that do not provide us with basic data, you know, are not going to be eligible for very much longer to take NHS patients. You know, this should have been said a decade or more ago, and we now have to say it today. And as I've explained, the benefits of that are so obvious in patient care and so on, but maybe not as obvious in driving this massive economic opportunity I've just described. So that's kind of the data piece. And I just wanted to quickly touch on two other components of this kind of vision that we're developing for the Commission, well, for the NHS, in fact, more broadly for health as a whole. So the first is participation. And, you know, it's been in the public domain, but I might as well say it again, that, you know, by the spring of 2015, every patient in this country will, if they wish it, be able to get online access to their medical records. And they will be able to do things like book online prescriptions, book online appointments. And the reason for that, again, is not just customer service, though that should be an imperative for us. It sort of seems to be like a basic civilized standard. It's because it's going to make primary care physicians spend, or it will enable them rather to spend more time with the people who most need their attention. And I can give you the facts and figures, but broadly put, and we're going to have to do more work, and I'm not going to stand behind this figure, but a figure that I've seen which is in the public domain is that might save us something like £6 billion over the course of the next 5 years. And I actually personally believe that's probably an underestimate, but the budget of the NHS is 100 billion. If we could start getting into that kind of percentage saving from doing nothing more complex and more popular than effectively introducing online banking into healthcare, that's pretty impressive, and that will happen. Second thing I just wanted to say was that the third sort of component is to do with this it's under participation in a way, but it's sort of, you know, frankly, what do we do with connected health? How do we make the technology legacy work now for the new health service? You know, we've invested an absolute fortune in it, and we are continuing to invest quite rightly a fortune in it. So what are we going to prioritise? And I inadvertently tweeted a few weeks ago, that we would have a paperless NHS by 2015. So I want to add a little word in the middle of paperless, just to, which is to say that we will have paperless referrals by spring 2015. So for those who know this, we're going to be relaunching one of the most controversial, frankly disliked technology platforms that the NHS has developed called Choose and Book. And we're going to relaunch it, and we are going to make everybody have the opportunity, there will be no more paper associated with referrals by spring 2015. We've got a lot of work to do to explain quite reasonably to GPs why this is going to be different and why it's not going to be wrong and the data is going to be flawed and all that stuff, but that's another important thing you can hold me to account for. So you've got three things. You've got the data, you've got online sort of digital primary care, and you've got paperless referrals in the NHS. And I just wanted to finish with a story that just, in a way, I hope exemplifies the kind of the challenge, because I don't think this is really, as I said at the beginning, got anything to do with technology. I think this is all about us as patients and us as doctors and nurses beginning to reflect on the amazing opportunity we've got to be literally a globally field-leading health service in so many different respects. We already are in so many, but we really could be the exemplar for the world. And it's interesting, whenever I meet, you know, a foreign health minister or whatever, they are all watching us now. I mean, everybody's watching the NHS, and you feel that pressure, actually. But I recently, my son, who's 16, recently lost his memory. And, of course, I said, this is the time you tell me if you've been taking any of those mushrooms. And he denied that it was anything sort of that nature, and it does later appear to have transpired he may have knocked his head and not remembered it. But anyway, he banged his head somehow and ended up losing his memory. And we were in Musgrave Park, which is my local hospital in Taunton, and he was going to be transferred up to Queen's Square, which is the fabulous neurological hospital in London. And they wanted us to bring the MRI scan with us, you know, in the car, as it were. And so the guys in Taunton said, well, look, I tell you what, you're going to have to wait 3 or 4 hours because I'm going to print the CD off for you. And I said, hang on, this is really embarrassing. I'm technically sort of overseeing the technology infrastructure of the NHS. And we've invested a fortune in you having this cool system that allows you to email these MRI scans from one place to another. And why don't you try the email? Because I don't want to wait 4 hours for you to print the CD. He said, look, I tell you what, I know that's what you've been told, sir, but I can assure you it doesn't work, and you'll be prepared to wait for the CD. So I rang the guys at Queen's Square and said, yeah, he's absolutely right, it won't work, just you'll have to wait for the CD, and we need the CD because we're not going to run it again, etc. So I took this risk. I said, look, just send it on the email. I don't want your CD. He sent it on the email, shrugging his shoulders, saying, well, this is not going to work, I can assure you. Got to Queen's Square, you know, world-class professors of neurology, etc., saying, well, I tell you what, it won't have landed, but we'll have a look. But you know, and of course it had landed, and they were all going, like it was a miracle. You know, they were regarding this as a miracle. And so I just leave you this thought that maybe it isn't necessarily as far from where we're at the moment, but there's a lot of sort of work that I personally and everyone collectively in this room needs to do to get the story out there of why this matters, and everyone needs to start engaging with it. Anyway, just some thoughts. Thank you.
Thanks, Tim.
Great stuff. Rohan, over to you. Your reaction to that?
Yes. Well, if it's okay, Tim is part of the commissioning board, which has been set up to insulate the NHS from political interference. My little scheme here is to drag you back into the political gutter and to just take a few minutes just to explain why it is that the Prime Minister, the Chancellor, Jeremy Hunt, David Willits, you know, the Conservative side of the coalition, but also Liberal Democrat partners, place such emphasis on this agenda, on the tech agenda, on the open data agenda, and what we're going to be doing on this in the weeks and months ahead. I thought a helpful way of starting would be just to touch on the infamous NHS supercomputer, Connected for Health, which wound up costing somewhere in the region of 18 billion pounds. It was projected to cost, what, 2 at the outset. And I think a lot of people in Westminster, a lot of people in Whitehall, in think tanks, probably construe that, interpret that as a failure to do with contracting, a lack of expertise when it comes to negotiating. But I would argue that there's something much deeper going on, and that your approach to IT, at least amongst political parties, maps onto our ideologies and our approach more broadly. And I think you can see something much more interesting and frankly disturbing about the way the last government approached this kind of project. And I hope, we're trying to do something very different. So Connected for Health, what went wrong? Well, problem one was that, as was the last government's approach, when data could be collected using IT, the instinct was always to collect as much of that data to the centre as possible in order to make better decisions, rather than to empower individuals, clinicians, the wider world with that information. The instinct was always, you see this right across the board, collect that data to the centre. And I think that maps onto a certain sort of commanding heights approach to data. Problem one. Problem two was that there was a cosy corporatist relationship between the NHS, between Whitehall, and the IT providers. And you saw that in the way that these contracts were set up. A handful of contracts, each 3, 4, 5 billion pounds by the end. And of course, there's only a handful of companies anywhere in the world that can handle a contract of that size. So sure enough, you have this oligopoly of providers. And the final problem with it, I would argue, was that it was a top-down, hubristic, giant system. One size fits all. It wasn't a system based around open standards, saying to GPs, look, here are the protocols that any system you buy off the shelf needs to work to, but you go out, let 1,000 flowers bloom. Let's just make sure all those flowers speak the same language, and you're away. So I think there were 3 big problems. And everything that Tim is describing, everything that Tim has done as Director of Transparency at the Cabinet Office, now at the NHS, is really part of our mission, our revolution to overturn 13 years or so of closed, top-down, oligopolistic IT systems. And why are we trying to do all that? So those are the reasons I've talked a bit about with the NHS supercomputer. why those systems didn't work. But why do we think what we're going to do could work? Well, one big hunch we have, and this is already borne out in the data, in the results, is that an approach that's more open, that's more bottom-up, that features small companies rather than just big companies, will save a huge amount of money. When we were elected in May 2010, central government spent about £7 billion a year on IT. The public sector as a whole, 15 billion. And that £7 billion of central government, 70% of it went to just 7 IT companies. 70% to just 7 companies. And in procurement generally, 95% of government contracts went to firms with more than 250 employees. Just 5% of government contracts went to small companies, small or even medium-sized companies. You had a real lock, big government working very closely with big business in a way that is not great for cost. And Nassim Taleb, who's in town at the moment, I think is very good on the reason why that model is not good for cost. Partly because it means you have insufficient competitive tension for contracts, you only have a handful of bidders. But also in IT, complexity scales. So efficiencies of scale are very, very limited IT. But if you're talking about a £2 billion IT contract, the risk scales potentially exponentially. More can go wrong. And putting a human face on this cost and how bad things have got. Francis Maud has some great statistics. He says that only about 5% of student loans are transacted online. So you've got 18-year-olds, 17-year-olds and 18-year-olds, digital natives, applying for student loans. Only about 5% of them manage to carry out that transaction online. Why? Well, most of them start out online, 99% plus start out going to the student loan website, but only 5% manage to get to the end because the process is so frustrating, so difficult. In pensions, according to Francis Maud, so I'm using his stats, so passing the blame, but he makes the point that only 7 pensioners last year managed their state pension online. 7. He assumed that it must be 7% of pensioners, or 7 million, or 7 pensioners. And when he was told this, whoever it was that was carrying the news said, oh, well, but these are pensioners, we're not talking young people here. Well, Francis Maud looked into it, and 40% of pensioners manage their bank account online. So, and every single one of those transactions, be it on student loans, be it on pensions, be it anywhere else, when those transactions are done face-to-face, via the telephone, using paper, and you see this right across the NHS, the costs are huge. You're talking 15, 20, 25 pounds per transaction rather than 20 pence per transaction. So you've got a big problem there on cost. And we've taken out already, and I think this is in the public domain, if not, this is new. We've taken out about £1.5 billion so far of the £7 billion IT spend. And I think we can cut that by 50%. I think we can go from 6 billion, which we've got it down to, we've got it from 7 to below 6. We can cut that in half in the next couple of years, and all the while improve the quality of service. So you could be, you're talking about big savings just through a different approach. Just very quickly, Tim has touched on data. Big benefits on data as well, of this kind of open approach on IT. But I sometimes hard to realise for me that just 2.5 years ago, even the most basic data wasn't published by the government. You couldn't see line by line items of government spending. Government contracts weren't published. Crime data wasn't published on a street-by-street basis. School data, hospital data, none of this stuff was published, oftentimes at all. Other times it might have been published but buried in big reports rather than put in the right kind of format for people to use. McKinsey have done a fantastic study looking at the value that this data might have. I think 200 billion was the European figure. Cambridge University had a conservative estimate of £6 billion of economic growth that this would catalyse if you really open up the data that government has locked in its systems. And I often make the point that I think this is a sort of Hayekian sort of IEA argument for the 21st century. That the reason that many of us on the right believe that markets are the right way to go is not that they generate wealth, because they don't always, but rather that great things happen when you make use of distributed information, when you're not relying on a handful of closed experts at the centre, but rather on the ideas and effervescent innovation from potentially millions of people everywhere. And that's what this open data agenda is about from a political perspective, and why we think it's so catalytic from a growth perspective. The final thing I just want to touch on is this growth point. And you know, there are many ways in which I think what Tim's talking about on data and IT can help support growth. And data can, opening up procurement to SMEs can. But in the next week or so, the Prime Minister is going to be setting out our vision on genomics, on genetic data. And about this time last year, he published the UK Life Science Strategy. And one of the big changes in that was an announcement that patient data will in future be shared with researchers unless the patient opts out. And that's a change in default. And this was announced last year, it's being implemented now, it's a very sensible policy, and it's really making use of this incredibly valuable asset that the NHS has. The American health system is much more fragmented, other health systems much more fragmented, and one of the advantages of the centralised NHS system is the central collection, in theory, of data, and the ability to share that data in a safe and secure and anonymised way with researchers to really develop next generation technologies and treatments and drugs. And this genetic revolution, the Prime Minister is really going to be ushering in next week. And you know, I'm not going to preempt that, but it's all of a piece with this. It's about using IT, using data to help stimulate growth, but critically also to reduce cost in government and to improve the quality of public services. So a really exciting agenda, and I think it says something, as I say, if you forgive the politics, about our approach to policy making and politics, which wherever possible is about empowering people rather than trying to accumulate ever more power and information to the centre. Thank you.
Very good stuff. Now, there's two very thought-provoking speeches. Now, I'm sure you will all have lots of questions. There is somewhere in the mix a roving mic, which you will try and get to you through the crowds. If you can start by saying who you are and where you're from, and particularly who you want to answer the question. We'll start with the gentleman in the white shirt.
Hi, yes, it's William Heath, and I'm from Midex. We do personal data stores. Hi. Thank you very much for two stimulating talks. I've come straight from the Open Data Institute launch, so I'm very mindful of open data and these things. I wonder, Tim, Ro, maybe both of you. Obviously, open data is powerful and has done a lot for government. How would you distinguish between open data the NHS could release and personal data, such as a personal health record, and also in an era in which there are more and more complete population data sets, it becomes increasingly possible to re-identify any data which is actually unique. So would you feel that if an anonymized health record could be re-identified, if it was susceptible to re-identification, that it should be treated as personal data and not as open public data?
Now, just because there's a lot of questions, we're going to take maybe two at a time. There's a gentleman just behind you. We'll hold up that very good question. There's a gentleman in the purple shirt as well.
Hi there, it's Roger Taylor from Dr. Foster. It's a question for Tim, actually. If you're a finance director and you inaccurately record the revenues you received or how you spent your money, you risk being prosecuted and sent to jail for some time. Despite the fact that the consequences are potentially considerably worse, if you, as a healthcare provider, fail to record accurately what you did to your patients or what the outcome was, you suffer almost no consequences whatsoever. When do you think you will fix that problem?
Okay, it seems like a pretty pointed question. Who wants to go first?
Oh, I was just thinking too. I hope we get a third because I could ignore it. Look, I didn't go into it, and I should have done, but there's a lot of work being done on how we kind of do the deal with us as patients and citizens in relation to data. So what we're proposing is a much greater use of our data to improve the quality of our outcomes as patients and all these other benefits we've described, growth, etc. In return for which we want much stronger, simpler guarantees that relate to the safe handling of that data. So, you'll know this already, of course, but Fiona Caldecott is doing another review, which I'm pretty involved in, which will really help dramatically simplify the security of what's called anonymized data. One of the important things she'll also do is define what that actually means in practice, because we're using these words in very different ways depending on the context, and the sort of taxonomy of the language is a really important part of how we get to the right answer. But so essentially there will be no identifiable data definition that's ever released by the NHS to any third party without the consent of the patient. That's like so that A is the law, and B, that will continue to be the law. And what we will do is clarify that more frankly and openly as we develop this argument for more of the anonymized data, again definition, being made available to people to improve your healthcare. So that's I thought it was a criminal offence for a doctor to knowingly misreport data in their record. I think there's an issue about inadvertence, which is what I think you're getting at. So if you're a finance director, yeah, I think it is already. I think it's a criminal offence because that's what Shipman was doing, and one of the offences for which he was actually, charged was not, of course, just killing people. It was actually deliberately misrecording their, symptoms in his records. But look, I mean, clearly one of our biggest issues, more broadly put, is the fact that we've got massive problems with data quality, which flow directly from ways in which doctors and nurses and others, the healthcare professionals, take care about their data. So one of the good things about greater transparency, as we know from other sectors, is that drives up data quality. But let's be absolutely clear now that when I described to you a kind of world, new oceans of health data being made available to people, the very first thing that will happen will be a national crisis over how bad it is, before we get on to the opportunities it offers for future benefits. So we should be ready for that. We should be ready that data quality is a real issue because this stuff hasn't yet been exposed to sunlight.
And that data quality point, before answering William's question, when we were first elected in the first week or two after the coalition agreement had been signed, we were planning a letter from the Prime Minister to government departments saying, here are the data sets you need to release by which date. And we circulated around the senior civil service just to get sign-off and buy-in. And the letter kept coming back with some words tracked in saying, no data will be released unless the quality can be assured. And we kept taking it out, and it kept being put back in by faceless bureaucrats and doing their job. And and we were eventually sick of this sort of game. I asked why. Why is this being added in? Answer came back. Well, if data is released that is not accurate, it will embarrass the civil service. It will embarrass the public sector. And our argument was that, well, if you're making decisions based on sort of bad data, that is just embarrassing. And as Tim says, it is through the release of data that people can start to question it, can point out where errors have taken place. We saw this a lot with crime data as that started to be published, that people were calling their local police force and saying, hang on, I think that's the crime I complained about, but you've marked it down on a street, five blocks over rather than where it is. So that feedback loop, I think, is really important. On William's point about, I made 2 points. One about people holding their own personal data. I mean, we think that's incredibly important, and we've recently launched an agenda that we called My Data, and we're going to apply this to government as well as to the private sector. With government, it wraps in with what Tim and Jeremy Hunt have talked about, people being able to have access to their own health record, to essentially hold their own health record, share it with who they like, and so on. Really important personal empowerment point. But this applies to the private sector too, which I think is interesting. So credit card information, the way in which you've used your credit card over the past year, your supermarket store card data, data about how you've used your mobile phone over the past year. these are very valuable data files to you if you want to use sort of next generation price comparison sites, say, where you want to know what your carbon footprint is from your shopping and so on. I mean, who knows what kinds of third parties will pop up to help you make use of that data and explore ways of, you know, getting a better deal or finding other products. And so that's very important. I think the interesting thing there, from a centre-right perspective, is that, you know, there is, at least in theory, an initial regulatory burden in saying to certain companies, you should make that data file available to consumers who want it. But the reason, you know, we want to go down that route, and the Chancellor has said that we will introduce legislation if necessary, is because we think it's going to be so catalytic for growth. You know, William, the thing you're talking about, people holding their own data, is just incredibly important. And I think it's going to be one of those areas, a bit like government data transparency, that in a few years we'll wonder how, you know, that wasn't the case before. I think that change will come quite quickly.
A couple more questions. There's a gentleman at the back of the crowd there, and we'll take.
Hi, Greg Hadfield. I'm interested in the self-management of health and how maybe by releasing individual data, I as an individual can share it with others. So together we can build applications and services. So say I've got type 1 diabetes, I can learn and work together with other individuals to self-manage my own health, take the burden off the NHS, as indeed is the government's position, but also have a better experience of managing my own life.
Yeah, that's a good question. So we'll take that together with, there was a gentleman right in the second row here, in the purple shirt, and the microphone's just coming to you.
Thanks. I'm Hitan Shah from the Royal Statistical Society, and it's a question to both of you. Really about how do we get from A to B? I mean, it's a great agenda. We're very supportive of it, but two barriers at least, which have come up in both of the talks, I think. One is around the statistical skills or the data handling skills within the civil service, public servants, etc. And the second is the cultural change that you need to create, and some thoughts on how you're going to move us from A to B on that would be really helpful.
Each of you want to take one of these? Or?
Shall I do the data? Because being a faceless bureaucrat, I can speak to the capabilities question. This is a really serious problem, and there's quite a lot of stuff that I haven't talked about related to how do we maximize the productivity in a way, the effectiveness of the small resource that does currently exist, and how we very quickly create a much bigger pool of talent to be able to, actually, frankly, it doesn't even get to statistics. It's, right now it's just about handling, as you said, it's data handling. It's, you know, we need, to do this, we need at least world-class data centers. And at the moment, we don't have anything that really gets close to that. So the journey is going, I can see how we get there, actually, and perhaps this is something to talk about offline, but certainly that's the first step. Then I think there's a bigger question about the statistics piece, because obviously I come from originally Dr. Foster, and I'm a great believer in the market playing a role in driving value out of raw data. So my key focus actually isn't that added value layer, it is just the raw data being made available with appropriate safeguards and consents. But there is a genuine challenge there around the capabilities that exist. So it'd be interesting to talk to you about that.
On the people coming together and self-managing, I think it is a culture change, right? Someone told me a story, and I think this is right, that in the 1950s, a British guy had diabetes, and he was, back then, if you had diabetes, you have to go into the hospital several times a week to have your blood sugar levels tested. And he invented his own little pen to analyze his own blood. And it took 10 years of fighting for him to be allowed to sort of self-manage and for that to become the kind of norm. Because, your doctor in India, it is a culture change. There are great examples of it emerging already in the States, and the website Patients Like Me is a big favorite of ours because it allows people with chronic health conditions to get together, to talk to one another about their care, to publish and share their drug regimens, how they've responded to it, rate doctors, and so on. They can be contacted by people that are running clinical trials. It really is, I think, a sort of living embodiment of the kind of vision that Tim is setting out. But it is a culture change, and that's why, as Tim says, the more people who understand this agenda and can help us overcome the barriers that undoubtedly lie ahead, the better.
Okay, so there's a gentleman in the fourth row back. Just if you come forward a little bit, there's just a chap here.
Thank you. Hi, I'm John Lindberg from Intellect, the UK trade body for technology industry. It's mainly for Rowan and also for Tim. You talked about the procurement and difficulty for SMEs, and you want to get them a bigger slice of the market. And I know, Tim, you also want to, especially startups. I have around 200 or plus SMEs engaged in the health market. I think the biggest barrier they face is when they go out and want to tender for something, they're faced with this requirement that says you have to have £10 million turnover for the last 10 years or you can't bid. How can we overcome that to make it a bit easier for them?
That's a very interesting question. Take that, and there's a man straight behind you.
Hi, Neil Griffiths from Capita. Tim, a couple of times when you were talking, you said this isn't just about customer services, but my background's in clinical risk, and quite a few years ago now, when I was surprised to discover actually not just in healthcare, but actually in any industry sector, the organisations that had good customer services tended to have much lower risk profiles. They tended to be much better at risk management. And there's all sorts of interesting reasons why that might be. And there's particular evidence in the health sector, most of it actually not from the UK, that healthcare organisations that are good at customer services have particularly good low clinical risk profiles. So actually, is not customer services a good reason why the pinstripe clinicians and those actually should really be supporting what you're trying to do? And you know, it might be possible to be a little bit kind of clearer about that and the evidence behind it.
That seems like one for Tim, because you'd already mentioned the SMEs.
Yeah, well, no, I totally agree. So I didn't, I mean, for those who, I can see a number in the room who've worked with me before or are working with me now, you know, we have a fairly specific model of benefits, which I haven't gone through, but certainly we don't, you know, the customer services kind of domain, as it were, is as important as, say, quality or productivity. And so I think broadly, I completely agree. Do you mind if I pick up that point about SMEs? Because, and it relates a little bit to Greg Hadfield's point earlier about the sort of self-management. So one of the most important things we'll do next year is to relaunch NHS Choices, NHS Direct, and 111 as a kind of seamless, integrated customer service platform, so just use that phrase. And the idea of this is that we will effectively create an open API for all comers to sort of, you know, market their services and products. And so this is about health tools, it's about services, it's about creating a marketplace. And you know, one of the things we're going to have to do to get that procurement to work properly is to find a way of not using the frameworks that are currently, you know, generally in play. But I think it's really important that people get, because it's been so long, and of course I came from an SME, you know, some time ago, but it's been so long and no one will believe this, but there really is a genuine, passionate commitment to finding ways in which we can not stop systems integrators. I mean, because they've got lots to offer, but enable a fairer marketplace for SMEs and others, and not-for-profit social enterprises and so on, to engage with this opportunity. Because, you know, there are so many obvious reasons, but innovation and so on and so forth. But, you know, I'm saying it sort of personally because you don't have to believe me, but really that's the case. And, you know, over time, I hope quickly you'll see evidence of procurements not using the standard frameworks, and finding and being more creative about how we do offer SMEs a real way into this opportunity. But I just wanted to say that.
Yeah, and just to add to that, as I said, central government was spending £7 billion on IT when we were elected. We've taken £1 billion, £1.5 billion out of that. And one of the ways is central government contracts tended not to have the £10 million requirement, but used to say you've got to provide 3 years worth of audited accounts in order to bid for a contract. So unless you were already more than 3 years old, you were locked out of the system. They would often also say you had to provide past experience of delivering a government contract in order to win a government contract. And so we've stripped those out. Now, local government, the NHS, are outside of the controls we've so far put in place on, you know, sorting out this kind of mess. But you know, that's why this guy's here. He's gonna, you know, he's gonna fix all this. Right?
So no pressure there. Dan Lewis in the pink shirt, just there.
Thanks very much. Dan Lewis from the Economic Policy Centre and UKCrimestats.com. Do you agree with the principle that government should just release data and not develop it? I only ask this because with UKCrimestats.com, we've had some trouble competing with a tax-funded rival in police.uk, which has first use and discriminatory access to the data and is in effect a monopoly. That being so, are you able to give some assurance with this health data to any developers in the room that someone within the NHS won't actually develop it themselves?
That's an interesting
Great
one.
question.
And there's a question right next to you as well. Just there, gentleman in the striped tie.
Hi, Simon Hill from Cerner. Tim, great news about Choosing Book because it's our software that underpins it. At this stage, I should declare an interest because Cerner had about half of the NHS supercomputer contract, although I stressed to add we had the half that worked. It builds on Roger's point and also the point from the front. Rowan, you're absolutely right. One of the biggest problems you have with the NHS supercomputer was the top-down approach. So that when you go and try and implement the systems, actually the NHS staff don't have an incentive to do it. They're told to do it. They don't see the benefit of doing it. That's a massive, massive problem if you're going to do what you're intending to do. And we're big supporters of you doing what you intend to do.
Yeah.
So the question is, how are you going to go and change that? It's a cultural issue. But realistically, I suspect you probably want to look at the United States, the meaningful use legislation they have over there. I know that Tim's probably looked at that before. And I think you also perhaps want to think about sequence and quality standards, perhaps potentially looking at putting together a quality standard, cross-cutting quality standard on information. I know that's a bit sort of geeky talk in terms of NHS, but I think without those financial triggers and drivers to do it, you're going to really struggle. It's retrospective, but I think that's probably what you're going to need to do it.
Two great questions there. So one on this old question about government as retailer or wholesaler, and this other one about, particularly like to know more about meaningful use.
Well, I'll take Dan's then, if that's all right. Do you know what? I think we're still, to an extent, feeling our way on this. And so our position has always, my position has always been quite a purist one, which is government should just release the data and let people do great things with it. And the Home Office essentially defied our sort of, crappy sort of writ and went and spent 250 grand, I think, on their crime map website. And the interesting thing about it, and I appreciate, it means you've got a big, bulky, state-funded competitor, but it had, I think, 6 million hits that first day. And we've maintained the purist position, don't get me wrong, but the Open Data Institute, which was opened today by Francis Maud, which is headed by Tim Berners-Lee and Gavin Starks, and amazing people. It's based in Tech City. What that's about is essentially using government to kind of help stir the pot, because we've released a lot of data, and we want to see more great applications built off the back of it. And yours is a brilliant example. And if you feel that the crime website has access to that information in a way that is preferential, then let's talk about it offline, because that's wrong. But what we are going to do much more of in the next kind of 12 months is just stir the pot. We've done a bunch of hackathons, but we're going to have more in the way of kind of challenge funds and prizes, using the Open Data Institute, using Tech City, using clusters like Cambridge to really kind of bang the drum for this data. And it's that, we're not going to stop being purists. We think if we release the data, great stuff happens. But do we think that we need to do more to kind of cajole and cheerlead for this stuff? Yes, I think that's where we're moving on to.
That's interesting. Would you say it's a bit of a change of tone? When this government first came in, I detected a sort of quite a laissez-faire approach. There was a hope that things would just happen, and now...
Yeah, exactly. And I think, to be honest, it's partly, when it comes to central government data, we've basically got all of it out that we could get out. There's a bit left in your domain, but in central government, a lot of it is out. So it's phase one was always just get this damn stuff out. It's been locked up in government service for too long. But now I think it's about cheerleading, but critically not crowding out your kind of innovation. So let's definitely talk. If you feel that there's something unfair going on, let me know. But if we can cajole without crowding out, that'd be pretty great.
Good. And Tim, do you want to?
Do you know, I was just remembering how angry I used to feel about being completely kiboshed by a state monopoly in healthcare when we were setting up Dr. Foster. I've completely forgotten what Simon's question was. Just remind me what it was.
It's how are you going to incentivise the NHS to do what you want them to do?
Oh, yeah. Okay, so I can't answer it because this planning guidance will, I hope, provide some helpful steer. You'll be surprised.
Good. Gosh, there's lots of questions. We're going to come to the front for a question here, and then we'll go to gentleman in the blue top.
Thanks. Jeremy Thomas, the trustee, the Bow Group. If we're to make the most of the potential which this technology holds for us, how far can we best do that through the existing hierarchy and bureaucracy of the Department of Health? And how far might it be necessary to establish a discrete unit associated with the Health Ministry which would have wider powers? Now, the example I'm thinking of, and I'm shamelessly following you into the political gutter here, is the example of Dennis Healy's procurement evaluation group in the Ministry of Defence in the 1960s, when he would take outside scientists and go-ahead middle-ranking officers and put them together. In the same way, thinking of Tim talking of the tech-savvy doctors and nurses who could see the point, who could see what this would do, if there could be some kind of, dare I say, independent medical statistical authority, IMSA rather than IPSA, which would have authority to direct, to get the data out, and to make the most of this. Because after all, the more people it's got to, the more people, the more ideas.
Interesting, very interesting point. We're going to go to the gentleman with the iPad. Oh, that's a bad thing to say.
Yeah.
Hi, Benjamin Bell from Wonga.com. First of all, I just want to say that I think the open data and transparency agenda of this government will be viewed in some years to come as one of its great legacies. So well done, I really endorse it. As a data business, we purchase and make use of an awful lot of publicly available data. But what actually sets us apart is our analysis of behavioral data, how customers interact with the website, and many things are like that. How do you anticipate the NHS can sort of make similar analyses of how people interact with the services, i.e. behavioral data, the dynamic data, rather than just the static stuff such as publicly available data?
So it's two good questions. One about the kind of structures, and I know lots happened on structures, and then...
Yeah, so just on that second point first, so what I would call risk predictive modelling, which is or risk profiling, is actually the NHS is pretty advanced at that. If we had more data, we would be producing much richer risk profiles. But I don't know, Phil, pretty much every GP is now, not every, but a large number of GPs, for example, would routinely be risk profiling their patients in relation to admissions into hospital and other characteristics. So oddly, and partly because actually doctors are very clever people and are quite used to statistics, it's been a rare, where it's obvious, where the business benefit is obvious, these kinds of information tools are finding their way quite straightforwardly into the daily routine of the clinician, which offers us all hope. In fact, that's the reason I'm doing this job, because I believe that if we can explain the benefits case properly, and we will find that there's a very resonant demand from the clinical community for the sorts of things we've talked about. So actually, I'm feeling pretty good about the degree to which we've got predictive modelling. We need more data. We also do need more collaboration with industry to make that work. So I don't know if people are in the room, but there are lots of very good financially driven, I don't mean loan driven, but financially driven risk profiling data services which we are working with as it goes on. On the independent authority thing, I mean, I'd hope that in due course, and of course it's a reputation and that needs to be earned, that the NHS Commissioning Board would become regarded as a trusted custodian of the patient interest, and in that respect, unconflicted in the publication and diffusion of data through the system. But there is, and this is slightly more complex, there is, as those from the sector will know, something called the Information Centre, which was meant to perform the function you've just described, and probably hasn't quite done that but we need to collectively figure out how we make that concept work. So actually there's quite a lot of thinking going on in that space, but I'll certainly have a very interested look at the example you gave as well, that provides us with any useful, kind of context.
So now coming towards the end of our time, there's a gentleman in the second row, and then there's a lady in the third row there.
Hi, my name's Graham Kendall. I work with a number of organisations, Partners Network that represents independent sector providers, Esria Mapping Company and a number of others, but a lot of the work I do is in health data and getting that data out. And then doing some interesting stuff with it. One of the things that I found over the past year or so...
Is that on your microphone? I can hardly...
It is.
Put it closer to your mouth.
One of the things that I found over the past year or so is that while the overall direction of travel towards getting more data out is undoubtedly really welcome, some of the really interesting data sets and the detail around those data sets seems to be just falling off the radar. One example, I could give you several, is GPs offering choice of different providers. That no longer is being asked. Apparently, I was told, I don't know how reliable this is, that, well, it's flatlined. So the fact it's flatlined at about 45%, I think it's a key government policy, means that it's no longer worth collecting that information to show that the policy is not necessarily working. Kind of reminds me of the embarrassing bit. And anyway, there are several examples that I could give of really key parts of the data set that seem to be disappearing. And my question is, it's very hard at the point at which those disappear to have any kind of recourse or to be able to raise it, because it basically gets buried in the weeds. And we need some kind of feedback mechanism to be able to highlight the data that should be coming out is either not coming out or it's not coming out in the most useful way.
Disappearing data and feedback, and then there's a lady in the grey top there.
Louise Marston from Nesta, UK Innovation Charity. It's now possible for me to collect a huge amount of my own health data with my phone, with a pedometer, with a home blood pressure monitor. Is there an ambition to bring some of this data into the NHS to complement the data that's already there? And how do we see that fitting into the plan?
So, Tim,
shall I just quickly... I'm looking at Antonia, who runs data.gov, and I'm thinking rotten links, and I'm thinking, Christ, not another. So if we're guilty of a rotten link, if I can put it like that, then we need to solve it. But I don't think that particular data set has... Yeah, so the issue that I think you're more importantly raising is how can, as it were, customers, data customers, as you all are, raise, in a continuous feedback loop, issues to keep us... hold us, well, not us, but hold the whole thing to account for our data quality, and that's a really important point. So, we are various plans afoot, let me tell you about them offline to do that, but it's a genuinely important point, which we shouldn't. So this is fundamental. I don't know if it hasn't come across properly, but I always think of it this like you've got government as a source of information for citizens and citizens as a source of information for government. And the neatest explanatory I can think of, and I've stopped using that because it's too boring, is the Boris Bikes thing, where you pick it up because you can find it. You can then communicate the wheel's fallen off, and that virtuous circle of information means the bike gets fixed and you can pick it up again. And it's sort of, in the end, things get better. And we've been average to poor on government as a source of information for citizens. We've been virtually zero on citizens as a source of information for government. You will see, I hope, some dramatic improvements in that second sort of arrow, some of which are very high profile, asking every patient whether they would recommend a service to a friend or family. That's now government policy and will be rolled out in certain health contexts by April 2013. But there are other much more personalised kinds of data flows, which I mentioned Patients Like Me, that's an example. But equally, you've got the whole telehealth mobile opportunity, which is in its infancy. But these are all parts of that data flow that we need to build.
Yeah. I mean, it's worth saying, I think Neil asked me to make this point. Any complaints you've got, Neil is going to be fixing when he joins the government.
Yeah, exactly. Yeah, so, all over to you.
So to an extent, this is all going to be sorted quite quickly. The question about data quality and the question about using personally generated data, my sort of experience of that came about 6 months ago. I was in the States and I was talking to an academic that I've been talking to for the last 3, 4, 5 years about open data. And I went and saw him and told him about all the data we've released, expecting a bit of a pat on the back. And he immediately said, started giving me grief because we aren't using data in government to aid our decision making. And it's, you know, you'd be amazed at what a kind of data desert Whitehall is. Massive decisions are made, very little data about how policies are working on the ground, how initiatives are going and so on. If you have data, it'll be kind of 3-month lagging indicator and so on. And so we decided we would try and create some kind of data dashboard that senior officials and ministers might use to improve their decision making. And essentially we became the kind of app developer as a result. And I was really surprised at sort of data quality of lots of data sets I'd fought to release. I'd essentially thought, right, you know, job done, you know, we've implemented it, you know, and trying to build things using that data was incredibly hard. But the reason that this kind of dashboard I think is important is not just because it will improve decision making, but it also means that when government becomes a customer of that data, they start to demand better information. And that demand also pushes in the direction of using data from outside of government. So we've had, if you look at unemployment data, the ONS produces fantastic data every kind of quarter. But ministers would really like to have a better sense of unemployment more rapidly than that. And so we've been using data drawn from people like Adzuna, who scrape across every jobs board in the country and give you fantastic real-time information about the labour market. You can use search queries from search engines, again, to look at people looking for job centres and job opportunities, just to pick up some kind of leading indicator rather than a lagging indicator about the state of things. Inflation data, you can get fantastic real-time inflation data from algorithms scraping online British retailers. And so, bringing all this together in a sort of visualization dashboard for senior officials, senior ministers, will, I think, improve the demand on the government side for better data quality and also help create that loop that Tim's talking about. So it's a really exciting agenda. Not one that we've talked too much about today, but Michael Barber, who ran the implementation unit, has been sort of kind enough to say that this sort of agenda using data visualization is what he would have done 10 years ago in the implementation unit then. And I think that the next couple of years we're going to really, with Neil leading it, is going to really help change that. It's going to be very exciting indeed.
Okay, we're really about to run out of time, but we're going to take one or two very last questions. We're going to really, really short questions if we can. The gentleman in the blue tie and then the lady in the blue top.
Thank you. Just to raise Tim's point, Tim said there's always a stupid doctor in the audience who asks a stupid question. Tonight, Tim, I'm that person.
Pinstripe seat? No.
Well, I can't afford it. Neil Bacon, I run an organisation called I Want Great Care. And actually, the point I was going to make has sort of been brought together, partly by your point, Rowan, about lagging indicators, and partly by the point you make about getting the data from the patients and the public and the users. I think what we're going to find, sadly, and I'm conscious I'm an exalted company, the classic lagging indicator is death. And to use mortality to measure how good or bad our health service is, it couldn't be more lagging. Interestingly, how can we improve on that? The paper that came out just a couple of weeks ago in a peer-reviewed journal showed clearly that when patients rate their hospitals, simple 5-star thing, like they rate their hotel, like they rate their restaurant, it is a very accurate predictor of mortality, readmission rates, and infection rates. And this work has been done increasingly in the UK and the US. It's predictive data, and it's the point that, unfortunately, a lot of the data that we're going to work hard to release, Tim, is going to be poor quality and is by definition going to be lagging. I really look forward to, and again, I'm totally supportive of that work, but I think if this is sort of health data 2.0 or 3.0, the next one's going to be health data 4.0, because patients and their families know, and to your dashboard, Rowan, that predicts what people say when they walk out of hospitals, what they say when they sit at the bed. Capturing that data will transform this agenda, and I hope we can add that on.
Yeah, of course.
What we're already doing.
Absolutely.
Very interesting. And then there's one last question.
One last question. You've mentioned, Rowan, several times about...
Who are you?
I'm sorry. I am Rima McCarrum. I'm at GlaxoSmithKline, and I'm also on the board of NHS London, so I've got a foot in 2 different places. You've mentioned a few times about the last government versus this government, and obviously the next elections are only a couple of years away. How much does the success of this current programme depend on the outcome of those elections?
That's It's a very political question to end on, suitably political notes. On this death as a lagging indicator.
Yes, I love mortality rates, and that's what I really want to say. No, obviously you're right. I mean, clearly that's why we're doing all the stuff that you're involved in. So I don't think there's any one indicator. I mean, the reason we're doing the clinical, there's so many reasons. I mean, it's not just for quality, it's for value. You can't do value based on, patient feedback. You cannot tell me how much the pharmaceutical industry, what the arrangements should be, the cost of drugs from feedback data from patients. I mean, there are so many different reasons, but it's about creating a sort of universe of instruments. So, of course, mortality data on its own is no good on its own, in the same way as I don't think, say, friends and families on its own will be, that I think we're all agreeing. But yeah, absolutely agree. Mm. And I couldn't possibly comment on that.
Yeah. Well, Nigel Lawson has an interesting test. He thinks that the measure of a truly meaningful policy is one that wouldn't be reversed by the next government. And I think where we've been able to release data, so spending data, crime data, health data, education data, where we've got that data out, Met Office data, etc., I don't think that would be reversed. I think the clamour for that data, the uses of that data, the economic growth, the social innovation, I don't think you can get that genie back in the box. But this broad thrust, which is around IT, which is about ensuring that smaller companies can win contracts, reducing the cost of IT, ensuring that always and everywhere it's the individuals that are in control, I do think that that would be under massive threat, because these things derive from a philosophy. And if your philosophy is, we think great things happen when you release data to people, when millions of people are empowered, then you end up with an IT agenda that looks like ours. If you believe, and it's a perfectly legitimate belief, I used to think like this, that a handful of experts at the centre can make all the right decisions, then you end up with an IT system like you had under the last government. And I think you would start to see, just as we very quickly pulled things in our direction, you would very quickly start to see systems closing up, big government contracts going to big companies, and so on. I think that would change, because it's a reflection of the philosophies of the two parties. And I don't think it's true that ideology is dead in politics. I think there is a very specific vision that the Labour Party has. We have a very specific vision, and that's reflected in this agenda as it is in lots of others. So I think where data's been released, that's pretty safe. But we're talking about a 5, 10, 15-year agenda, and that would look very, very different under a different government.
Very interesting notes for us to end on. I'm afraid we are out of time. Everybody here this evening has asked really, really great questions. It's a bit like sort of French cricket, watching all questions from all angles being thrown at our speakers this evening. We've been talking about leading and lagging indicators. Clearly a leading indicator of the level of interest in this important subject is the number of people in the room this evening. So thank all of you for coming, and thank you to our two brilliant speakers for their great stuff this evening. Thank you.
Thank you.